Welcome to This Week in Medicine, your filtered medical journal summary. Looking to stay up to date with the latest medical research but short on time? This Week in Medicine has you covered. Our AI-generated podcast provides you with a convenient, on-the-go solution to keep you informed about the most significant developments in the medicine field. Each episode offers a filtered and concentrated summary of key journal articles, allowing you to stay informed without the need to sift through pages of research papers. With This Week in Medicine, listening is faster than reading, and you can consume valuable medical knowledge while commuting, exercising, or during your daily routine. Hi, This Week in Medicine, we will be discussing. First, we will be discussing articles in New England Journal of Medicine. Empagliflozin after acute myocardial infarction. Background. Empagliflozin improves cardiovascular outcomes in patients with heart failure, patients with type 2 diabetes who are at high cardiovascular risk, and patients with chronic kidney disease. The safety and efficacy of empagliflozin in patients who have had acute myocardial infarction are unknown. Methods. In this event-driven, double-blind, randomized, placebo-controlled trial, we assigned, in a 1-to-1 ratio, patients who had been hospitalized for acute myocardial infarction and were at risk for heart failure to receive empagliflozin at a dose of 10 mg daily or placebo in addition to standard care within 14 days after admission. The primary endpoint was a composite of hospitalization for heart failure or death from any cause as assessed in a time-to-first event analysis. Results. A total of 3,260 patients were assigned to receive empagliflozin and 3,262 to receive placebo. During a median follow-up of 17.9 months, a first hospitalization for heart failure or death from any cause occurred in 267 patients, 8.2%, in the empagliflozin group, and in 298 patients, 9.1%, in the placebo group, with incidence rates of 5.9 and 6.6 events, respectively, per 100 patient years, hazard ratio, 0.90, 95% confidence interval, c. 0.76 to 1.06, p equals 0.21. With respect to the individual components of the primary endpoint, a first hospitalization for heart failure occurred in 118 patients, 3.6%, in the empagliflozin group, and in 153 patients, 4.7%, in the placebo group, hazard ratio 0.77, 95% C, 0.60 to 0.98, and death from any cause occurred in 169, 5.2%, and 178, 5.5%, respectively, hazard ratio 0.96, 95% C, 0.78 to 1.19. Adverse events were consistent with the known safety profile of empagliflozin and were similar in the two trial groups. Conclusions. Among patients at increased risk for heart failure after acute myocardial infarction, treatment with empagliflozin did not lead to a significantly lower risk of a first hospitalization for heart failure or death from any cause than placebo. Sequential CD7 CAR T-cell therapy and allogeneic HSCT without GVHD prophylaxis. Background. Patients with relapsed or refractory hematologic cancers have a poor prognosis. Chimeric antigen receptor, CAR, T-cell therapy as a bridge to allogeneic hematopoietic stem cell transplantation, HSCT, has the potential for long-term tumor elimination. However, pre-HSCT myeloablation and graft-versus-host disease, GVHD, prophylaxis agents have toxic effects and could eradicate residual CAR T cells and compromise anti-tumor effects. Whether the integration of CAR T-cell therapy and allogeneic HSCT can preserve CAR T-cell function and improve tumor control is unclear. Methods. We tested a novel all-in-one strategy consisting of sequential CD7 CAR T-cell therapy and haploidentical HSCT in 10 patients with relapsed or refractory CD7-positive leukemia or lymphoma. After CAR T-cell therapy led to complete remission with incomplete hematologic recovery, patients received haploidentical HSCT without pharmacologic myeloablation or GVHD prophylaxis drugs. Toxic effects and efficacy were closely monitored. Results. After CAR T-cell therapy, all 10 patients had complete remission with incomplete hematologic recovery and grade 4 pancytopenia. After haploidentical HSCT, 1 patient died on day 13 of septic shock and encephalitis, 8 patients had full donor chimerism, and 1 patient had autologous hematopoiesis. 3 patients had grade 2 HSCT-associated acute GVHD. The median follow-up was 15.1 months, range 3.1 to 24.0, after CAR T-cell therapy. 6 patients remained in minimal residual disease negative complete remission, 2 had a relapse of CD7 negative leukemia, and 1 died of septic shock at 3.7 months. The estimated 1-year overall survival was 68%, 95% confidence interval, C, 43 to 100, and the estimated 1-year disease-free survival was 54%, 95% C, 29 to 100. Conclusions. Our findings suggest that sequential CD7 CAR T-cell therapy and haploidentical HSCT is safe and effective, with remission and serious but reversible adverse events. This strategy offers a feasible approach for patients with CD7-positive tumors who are ineligible for conventional allogeneic HSCT. FFR-Guided complete or culprit-only PCI in patients with myocardial infarction. Background. The benefit of fractional flow reserve, FFR-guided complete revascularization in patients with ST segment elevation myocardial infarction, STEMI, and multivessel coronary artery disease remains unclear. Methods. In this multinational, registry-based, randomized trial, we assign patients with STEMI or very high-risk non-STEMI, STEMI, and multivessel disease who are undergoing primary percutaneous coronary intervention, PCI, of the culprit lesion to receive either FFR-guided complete revascularization of non-culprit lesions or no further revascularization. The primary outcome was a composite of death from any cause, myocardial infarction, or unplanned revascularization. The 2 key secondary outcomes were a composite of death from any cause or myocardial infarction and unplanned revascularization. Results. A total of 1,542 patients underwent randomization, with 764 assigned to receive FFR-guided complete revascularization and 778 assigned to receive culprit lesion-only PCI. At a median follow-up of 4.8 years, interquartile range, 4.3 to 5.2, a primary outcome event had occurred in 145 patients, 19.0%, in the complete revascularization group and in 159 patients, 20.4%, in the culprit lesion-only group. Hazard ratio, 0.93, 95% confidence interval, C, 0.74 to 1.17, p equals 0.53. With respect to the secondary outcomes, no apparent between group differences were observed in the composite of death from any cause or myocardial infarction, hazard ratio, 1.12, 95% C, 0.87 to 1.44, or unplanned revascularization, hazard ratio, 0.76, 95% C, 0.56 to 1.04. There were no apparent between group differences in safety outcomes. Conclusions. Among patients with STEMI or very high-risk STEMI and multivessel coronary artery disease, FFR-guided complete revascularization was not shown to result in a lower risk of a composite of death from any cause, myocardial infarction, or unplanned revascularization than culprit lesion-only PCI at 4.8 years. Nutritional support for moderate to late preterm infants, a randomized trial. Most moderate to late preterm infants need nutritional support until they are feeding exclusively on their mother's breast milk. Evidence to guide nutrition strategies for these infants is lacking. Methods. We conducted a multi-center, factorial, randomized trial involving infants born at 32 weeks 0 days to 35 weeks 6 days gestation who had intravenous access and whose mothers intended to breastfeed. Each infant was assigned to 3 interventions or their comparators: intravenous amino acid solution, parenteral nutrition, or dextrose solution until full feeding with milk was established, milk supplement given when maternal milk was insufficient or mother's breast milk exclusively with no supplementation, and taste and smell exposure before gastric tube feeding or no taste and smell exposure. The primary outcome for the parenteral nutrition and the milk supplement interventions was the body fat percentage at 4 months of corrected gestational age, and the primary outcome for the taste and smell intervention was the time to full enteral feeding, 150 milliliters per kilogram of body weight per day or exclusive breastfeeding. Results. A total of 532 infants, 291 boys, 55%, were included in the trial. The mean, plus or minus, body fat percentage at 4 months was similar among the infants who received parenteral nutrition and those who received dextrose solution, 26.0 plus or minus 5. 4% versus 26.2 plus or minus 5. 2%, adjusted mean difference, minus 0.20, 95% confidence interval, C, minus 1.32 to 0.92, p equals 0.72, and among the infants who received milk supplement, and those who received mother's breast milk exclusively, 26.3 plus or minus 5. 3% versus 25.8 plus or minus 5. 4%, adjusted mean difference, 0.65, 95% C, minus 0.45 to 1.74, p equals 0.25. The time to full enteral feeding was similar among the infants who were exposed to taste and smell and those who were not, 5.8 plus or minus 1.5 versus 5.7 plus or minus 1.9 days, p equals 0.59. Secondary outcomes were similar across interventions. Serious adverse events occurred in one infant. Conclusions. This trial of routine nutrition interventions to support moderate to late preterm infants until full nutrition with mother's breast milk was possible did not show any effects on the time to full enteral feeding or on body composition at 4 months of corrected gestational age. Next, we will be discussing articles from Journal of American Medical Association. Neurodevelopmental outcomes after late preterm antenatal corticosteroids. The ALPS follow-up study. Importance: the antenatal late preterm steroids, ALPS, trial changed clinical practice in the United States by finding that antenatal betamethasone at 34 to 36 weeks decreased short-term neonatal respiratory morbidity. However, the trial also found increased risk of neonatal hypoglycemia after betamethasone. This follow-up study focused on long-term neurodevelopmental outcomes after late preterm steroids. Objective: to evaluate whether administration of late preterm, 34 to 36 completed weeks, corticosteroids affected childhood neurodevelopmental outcomes. Design, setting, and participants: prospective follow-up study of children aged 6 years or older whose birthing parent had enrolled in the multi-center randomized clinical trial, conducted at 13 centers that participated in the maternal fetal medicine units, MFMU, network cycle from 2011 to 2016. Follow-up was from 2017 to 2022. Exposure: 12 mg of intramuscular betamethasone administered twice 24 hours apart. Main outcome measures: the primary outcome of this follow-up study was a general conceptual ability score less than 85, -1 SD, on the differential ability scales, 2nd edition, DAS2. Secondary outcomes included the Gross Motor Function Classification System Level and Social Responsiveness Scale and Child Behavior Checklist scores. Multivariable analyses adjusted for pre-specified variables known to be associated with the primary outcome. Sensitivity analyses used inverse probability weighting and also modeled the outcome for those lost to follow-up. Results of 2,831 children, 1,026 enrolled and 949, 479 betamethasone, 470 placebo, completed the DAS2 at a median age of 7 years, IQR, 6.6 to 7.6 years. Maternal, neonatal, and childhood characteristics were similar between groups except that neonatal hypoglycemia was more common in the betamethasone group. There were no differences in the primary outcome, a general conceptual ability score less than 85, which occurred in 82, 17.1%, of the betamethasone versus 87, 18.5%, of the placebo group, adjusted relative risk, 0.94, 95% C, 0.73 to 1.22. No differences in secondary outcomes were observed. Sensitivity analyses using inverse probability weighting or assigning outcomes to children lost to follow-up also found no differences between groups. Conclusion and relevance: in this follow-up study of a randomized clinical trial, Administration of antenatal corticosteroids to persons at risk of late preterm delivery, originally shown to improve short-term neonatal respiratory outcomes but with an increased rate of hypoglycemia, was not associated with adverse childhood neurodevelopmental outcomes at age 6 years or older. Associations between surrogate markers and clinical outcomes for non-oncologic chronic disease treatments. Important surrogate markers are increasingly used as primary endpoints in clinical trials supporting drug approvals. Objective to systematically summarize the evidence from meta-analyses, systematic reviews and meta-analyses, and pooled analyses, hereafter, meta-analyses, of clinical trials examining the strength of association between treatment effects measured using surrogate markers and clinical outcomes in non-oncologic chronic diseases. Data sources: the Food and Drug Administration, FDA, Adult Surrogate Endpoint Table and Medline from inception to March 19, 2023. Study selection: 3 reviewers selected meta-analyses of clinical trials, meta-analyses of observational studies were excluded. Data extraction and synthesis: 2 reviewers extracted correlation coefficients, coefficients of determination, slopes, effect estimates, or results from meta-regression analyses between surrogate markers and clinical outcomes. Main outcomes and measures: correlation coefficient or coefficient of determination, when reported, was classified as high strength, are greater than or equal to 0.85 or are 2 greater than or equal to 0.72. Primary findings were otherwise summarized. Results: 37 surrogate markers listed in FDA's table and used as primary endpoints in clinical trials across 32 unique non-oncologic chronic diseases were included. For 22, 59%, surrogate markers, 21 chronic diseases, no eligible meta-analysis was identified. For 15, 41%, surrogate markers, 14 chronic diseases, at least one meta-analysis was identified, 54 in total. Median per surrogate marker, 2.5, IQR, 1.3 to 6.0. Among these, median number of trials and patients meta-analyzed was 18.5, IQR, 12.0 to 43.0, and 90.056, IQR, 2109 to 170.014, respectively. The 54 meta-analyses reported 109 unique surrogate marker clinical outcome pairs, 54%, reported at least one or 2, 17%, of which reported at least one classified as high strength, whereas 46%, reported slopes, effect estimates, or results of meta-regression analyses only, 52%, of which reported at least one statistically significant result. Conclusions and relevance: most surrogate markers used as primary endpoints in clinical trials to support FDA approval of drugs treating non-oncologic chronic diseases lacked high-strength evidence of associations with clinical outcomes from published meta-analyses. Next, we will be discussing articles from Annals of Internal Medicine. Disparities in tuberculosis incidence by race and ethnicity among the U.S.-born population in the United States, 2011 to 2021, an analysis of National Disease Registry data. Background: elevated tuberculosis, TB, incidence rates have recently been reported for racial/ethnic minority populations in the United States. Tracking such disparities is important for assessing progress toward national health equity goals and implementing change. Objective: to quantify trends in racial/ethnic disparities in TB incidence among U.S.-born persons. Design: time series analysis of National TB Registry data for 2011 to 2021. Setting: United States. Participants: U.S.-born persons stratified by race/ethnicity. Measurements: TB incidence rates, incidence rate differences, and incidence rate ratios compared with non-Hispanic white persons, excess TB cases, calculated from incidence rate differences, and the index of disparity. Analyses were stratified by sex and by attribution of TB disease to recent transmission and were adjusted for age, year, and state of residence. Results: in analyses of TB incidence rates for each racial/ethnic population compared with non-Hispanic white persons, incidence rate ratios were as high as 14.2, 95% C, 13.0 to 15.5, among American Indian or Alaska Native, AI/in females. Relative disparities were greater for females, younger persons, and TB attributed to recent transmission. Absolute disparities were greater for males. Excess TB cases in 2011 to 2021 represented 69%, C, 66% to 71%, and 62%, C, 60% to 64% of total cases for females and males, respectively. No evidence was found to indicate that incidence rate ratios decreased over time, and most relative disparity measures showed small, statistically non-significant increases. Limitation: analyses assumed complete TB case diagnosis and self-report of race/ethnicity and were not adjusted for medical comorbidities or social determinants of health. Conclusion: there are persistent disparities in TB incidence by race/ethnicity. Relative disparities were greater for AI/in persons, females, and younger persons, and absolute disparities were greater for males. Eliminating these disparities could reduce overall TB incidence by more than 60% among the U.S.-born population. Next, we will be discussing articles from Nature Medicine. Nivolumab for mismatch repair deficient or hypermutated gynecologic cancers, a phase 2 trial with biomarker analyses. Program DEath-1, PD-1 inhibitors are approved for therapy of gynecologic cancers with DNA mismatch repair deficiency, dMMR, although predictors of response remain elusive. We conducted a single-arm phase 2 study of nivolumab in 35 patients with dMMR uterine or ovarian cancers. Co-primary endpoints included objective response rate, ORR, and progression-free survival at 24 weeks, PFS 24. Secondary endpoints included overall survival, OS, disease control rate, DCR, duration of response, DOR, and safety. Exploratory endpoints included biomarkers and molecular correlates of response. The ORR was 58.8%, 97.5% confidence interval, C, 40.7 to 100%, and the PFS 24 rate was 64.7%, 97.5% one-sided, C, 46.5 to 100%, meeting the pre-specified endpoints. The DCR was 73.5%, 95% C, 55.6 to 87.1%. At the median follow-up of 42.1 months, range 8.9 to 59.8 months, median OS was not reached. 1-year OS rate was 79%, 95% C, 60.9 to 89.4%. 32 patients, 91%, had a treatment-related adverse event, TRAE, including arthralgia, N equals 10, 29%, fatigue, N equals 10, 29%, pain, N equals 10, 29%, and pruritus, N equals 10, 29%. Most were grade 1 or grade 2. 10 patients, 29%, reported a grade 3 or grade 4 TRAE. No grade 5 events occurred. Exploratory analyses show that the presence of dysfunctional CD8 plus P.D. 1 plus, or terminally dysfunctional CD8 plus P.D. 1 plus tox plus T cells and their interaction with programmed death ligand 1, PDL1 plus cells were independently associated with PFS 24. PFS 24 was associated with presence of MEG8 or SET1B somatic mutations. This trial met its co-primary endpoints, ORR and PFS 24, early, and our findings highlight several genetic and tumor microenvironment parameters associated with response to PD-1 blockade in dMMR cancers, generating rationale for their validation in larger cohorts. Next, we will be discussing articles from British Medical Journal. Predicting the risks of kidney failure and death in adults with moderate to severe chronic kidney disease, multinational, longitudinal, population-based, cohort study. Objective to train and test a super-learner strategy for risk prediction of kidney failure and mortality in people with incident moderate to severe chronic kidney disease, stage GVHD G4. Design multinational, longitudinal, population-based, cohort study. Settings linked population health data from Canada, training and temporal testing, and Denmark and Scotland, geographical testing. Participants people with newly recorded chronic kidney disease at stage GVHD G4, estimated glomerular filtration rate, EGFR, 15 to 44 milliliters per minute / 1.73 square meters. Modeling the superlearner algorithm selected the best performing regression models or machine learning algorithms, learners, based on their ability to predict kidney failure and mortality with minimized cross-validated prediction error, prior score, the lower the better. Pre-specified learners included age, sex, FFR, albuminuria, with or without diabetes, and cardiovascular disease. Results: 67,942 Canadians, 17,528 Danish, and 7,740 Scottish residents with chronic kidney disease at stage GEB to G4 were included, median age 77 to 80 years, median FFR 39 milliliters per minute / 1.73 square meters. Median follow-up times were 5 to 6 years in all cohorts. Rates were 0.8 to 1.1 per 100 person years for kidney failure and 10 to 12 per 100 person years for death. K-Predict was more accurate than kidney failure risk equation in prediction of kidney failure risk, 5-year index of prediction accuracy 27.8%, 95% confidence interval 25.2% to 30.6%, versus 18.1%, 15.7% to 20.4%, in Denmark and 30.5%, 27.8% to 33.5%, versus 14.2%, 12.0% to 16.5%, in Scotland. Predictions from kidney failure risk equation and K-Predict differed substantially, potentially leading to diverging treatment decisions. An 80-year-old man with an FFR of 30 milliliters per minute / 1.73 square meters and an albumin to creatinine ratio of 100 milligrams / g, 11 milligrams / mol, would receive a 5-year kidney failure risk prediction of 10% from kidney failure risk equation, above the current nephrology referral threshold of 5%. The same man would receive 5-year risk predictions of 2% for kidney failure and 57% for mortality from K-Predict. Individual risk predictions from K-Predict with 4 or 6 variables were accurate for both outcomes. The K-Predict models retrained using older data provided accurate predictions when tested in temporally distinct, more recent data. Conclusions: K-Predict could be incorporated into electronic medical records or accessed online to accurately predict the risks of kidney failure and death in people with moderate to severe CKD. The K-Predict learning strategy is designed to be adapted to local needs and regularly revised over time to account for changes in the underlying health system and care processes. Next, we will be discussing articles from Lancet. Optimized Prevention of Postnatal HIV Transmission in Zambia and Burkina Faso, PROMISE-EPI, a Phase 3, open-label, randomized controlled trial. Background: transmission through breastfeeding accounts for more than half of the unacceptably high number of new pediatric HIV infections worldwide. We hypothesize that, in addition to maternal antiretroviral therapy, ART, extended postnatal prophylaxis with lamivudine, guided by point-of-care assays for maternal viral load, could reduce postnatal transmission. Methods: we did a Phase 3, open-label, randomized controlled trial at 4 healthcare facilities in Zambia and 4 healthcare facilities in Burkina Faso. Mothers with HIV and their breastfed infants without HIV attending the second visit of the expanded program of immunization, EPI-2, infant age 6 to 8 weeks, were randomly assigned 1-to-1 to intervention or control groups. In the intervention group, maternal viral load was measured using expert HIV viral load assay at EPI-2 and at 6 months, with results provided immediately. Infants whose mothers had a viral load of 1,000 copies per milliliter or higher were started on lamivudine syrup twice per day for 12 months or 1 month after breastfeeding discontinuation. The control group followed national guidelines for prevention of postnatal transmission of HIV. The primary outcome assessed by modified intention to treat was infant HIV infection at age 12 months, with HIV DNA point-of-care testing at 6 months and at 12 months. This trial is registered with clinicaltrials.gov, NCT 03870438. Findings: between December 12, 2019 and Sept 30, 2021, 34054 mothers were screened for HIV. Among them, 1,506 mothers with HIV and their infants without HIV, including 1,342 mother and infant pairs from Zambia and 164 from Burkina Faso, were eligible and randomly assigned 1:1 to the intervention, N equals 753, or control group, N equals 753. At baseline, the median age of the mothers was 30.6 years, IQR 26.0 to 34.7, 1,480, 98.4%, of 1,504 were receiving ART, and 169, 11.5%, of 1,466 had a viral load greater than or equal to 1,000 copies per milliliter. There was 1 case of HIV transmission in the intervention group and 6 in the control group, resulting in a transmission incidence of 0.19 per 100 person years, 95% C 0.005 to 1.04, in the intervention group and 1.16 per 100 person years, 0.43 to 2.53, in the control group, which did not reach statistical significance, p equals 0.066. HIV-free survival and serious adverse events were similar in both groups. Interpretation. Our intervention, initiated at EP2 and based on extended single-drug postnatal prophylaxis guided by point-of-care maternal viral load, could be an important strategy for pediatric HIV elimination. Next, we will be discussing articles from Journal of Clinical Oncology. Epidermal growth factor receptor tyrosine kinase inhibitors, final results of Checkmate 722. Purpose. The Phase 3 Checkmate 722 trial, clinicaltrials.gov identifier, NCT02864251, evaluated nivolumab plus chemotherapy versus chemotherapy in patients with epidermal growth factor receptor, EGFR mutated metastatic non-small cell lung cancer, NSCLC, after disease progression on EGFR tyrosine kinase inhibitors, TKIs. Methods. Patients with disease progression after first or second generation EGFR TKI therapy, without EGFR T790M mutation or osimertinib, without T790M mutation, were randomly assigned 1:1 to nivolumab, 360 mg once every 3 weeks, plus platinum doublet chemotherapy, once every 3 weeks, or platinum doublet chemotherapy alone, once every 3 weeks, for 4 cycles. Primary endpoint was progression-free survival, PFS. Secondary endpoints included 9 and 12-month PFS rates, overall survival, OS, objective response rate, ORR, and duration of response, DOR. Results. Overall, 294 patients were randomly assigned. At final analysis, median follow-up, 38.1 months, PFS was not significantly improved with nivolumab plus chemotherapy versus chemotherapy, median, 5.6 v 5.4 months, hazard ratio, HR, 0.75, 95% C, 0.56 to 1.00, p equals 0.0528, with 9 and 12-month PFS rates of 25.9% versus 19.8%, and 21.2% versus 15.9%, respectively. Post-hoc PFS subgroup analyses showed a trend favoring nivolumab plus chemotherapy in patients with tumors harboring sensitizing EGFR mutations, HR, 0.72, 95% C, 0.54 to 0.97, 1 line of previous EGFR TKI, 0.72, 95% C, 0.54 to 0.97, or both, 0.64, 95% C, 0.47 to 0.88. Median OS was 19.4 months with nivolumab plus chemotherapy versus 15.9 months with chemotherapy, while ORR was 31.3% versus 26.7%, and median DOR was 6.7 versus 5.6 months, respectively. Grade 3/4 treatment-related adverse events occurred in 44.7% and 29.4% of patients treated with nivolumab plus chemotherapy and chemotherapy alone, respectively. Conclusion. Nivolumab plus chemotherapy did not significantly improve PFS versus chemotherapy in patients with EGFR-mutated metastatic NSCLC previously treated with EGFR TKIs. No new safety signals were identified. Next, we will be discussing articles from Journal of Hepatology. An open-label randomized controlled trial of azathioprine versus mycophenolate mofetil for the induction of remission in treatment-naive autoimmune hepatitis. Background and aims. Patients with autoimmune hepatitis, AIH, almost invariably require lifelong immunosuppressive treatment. There is genuine concern about the efficacy and tolerability of the current standard combination therapy of prednisolone and azathioprine. Mycophenolate mofetil, MMF, has emerged as an alternative option. The aim of this study was to compare MMF to azathioprine as induction therapy for A. Methods. In this 24-week, prospective, randomized, open-label, multicenter superiority trial, 70 patients with treatment-naive received either MMF or azathioprine, both in combination with prednisolone. The primary endpoint was biochemical remission defined as normalization of serum levels of alanine aminotransferase and IgG after 24 weeks of treatment. Secondary endpoints included safety and tolerability. Results. 70 patients, mean 57.9 years, SD 14.0, 72.9% female, were randomly assigned to the MMF plus prednisolone, N equals 39, or azathioprine plus prednisolone, N equals 31 group. The primary endpoint was met in 56.4% and 29.0% of patients assigned to the MMF group and the azathioprine group, respectively, difference, 27.4 percentage points, 95% C4.0 to 46.7, p equals 0.022. The MMF group exhibited higher complete biochemical response rates at 6 months, 72.2% versus 32.3%, p equals 0.004. No serious adverse events occurred in patients who received MMF, 0%, but serious adverse events were reported in 4 patients who received azathioprine, 12.9%, p equals 0.034. 2 patients in the MMF group, 5.1%, and 8 patients in the azathioprine group, 25.8%, discontinued treatment owing to adverse events or serious adverse events, p equals 0.018. Conclusions. In patients with treatment-naive A, MMF with prednisolone led to a significantly higher rate of biochemical remission at 24 weeks compared to azathioprine combined with prednisolone. Azathioprine use was associated with more serious adverse events leading to cessation of treatment, suggesting superior tolerability of MMF. A novel treatment strategy utilizing panobinostat for high-risk and treatment-refractory hepatoblastoma. Background and aims. Patients with metastatic, treatment-refractory, and relapsed hepatoblastoma, HB, have survival rates of less than 50% due to limited treatment options. To develop new therapeutic strategies for these patients, our laboratory has developed a preclinical testing pipeline. Given that histone deacetylase, HDAC, inhibition has been proposed for HB, we hypothesized that we could find an effective combination treatment strategy utilizing DAC inhibition. Methods. RNA sequencing, microarray, nanostring, and immunohistochemistry data of patient HB samples were analyzed for DAC class expression. Patient-derived spheroids, PDSP, were used to screen combination chemotherapy with an DAC inhibitor, panobinostat. Patient-derived xenograft, PDX mouse models were developed and treated with a combination therapy that showed the highest efficacy in the PDSP drug screen. Results. DAC RNA and protein expression were elevated in HB tumors compared to normal livers. Panobinostat, IC50 of 0.013 to 0.059 m, showed strong in vitro effects and was associated with lower cell viability than other DAC inhibitors. PDSP demonstrated the highest level of cell death with combination treatment of vincristine/irinotecan/panobinostat, VIP. All 4 models responded to VIP therapy with a decrease in tumor size compared to placebo. After 6 weeks of treatment, 2 models demonstrated necrotic cell death, with lower Ki67 expression, decreased serum alpha-fetoprotein, and reduced tumor burden compared to paired VI and placebo-treated groups. Conclusions. Utilizing a preclinical HB pipeline, we demonstrate that panobinostat in combination with VI chemotherapy can induce an effective tumor response in models developed from patients with high-risk, relapsed, and treatment-refractory HB. Impact and implications. Patients with treatment-refractory hepatoblastoma have limited treatment options with survival rates of less than 50%. Our manuscript demonstrates that combination therapy with vincristine, irinotecan, and panobinostat reduces the size of high-risk, relapsed, and treatment-refractory tumors. With this work, we provide preclinical evidence to support utilizing this combination therapy as an arm in future clinical trials. Next, we will be discussing articles from Clinical Gastroenterology. Financial burden of hepatocellular carcinoma screening in patients with cirrhosis. Background. The overall value of hepatocellular carcinoma screening is defined by the balance of benefits and harms. Studies have only reported physical harms with none describing financial harms. Methods. We conducted a multi-center pragmatic randomized clinical trial of hepatocellular carcinoma screening outreach among 2,872 patients with cirrhosis from March 2018 to April 2021. Patients with positive or indeterminate results and matched patients with negative results completed surveys at baseline and at follow-up, measuring financial harms via cancer self-administered questionnaire and financial burden via comprehensive score for financial toxicity functional assessment of chronic illness therapy. Univariable and multivariable longitudinal regression analyses were performed to compare changes in financial harms across groups: true positive, true negative, false positive, and indeterminate. Semi-structured interviews were conducted in a subset of patients, sampled by center and test result. Results. Of 311 patients who completed at least one follow-up survey, 75% response rate, 37 had true positive, 133 true negative, 64 false positive, and 77 indeterminate results. Financial harms increased in true positive and false positive patients, with no significant changes noted among those with true negative or indeterminate results. At follow-up, 21.8% of patients reported moderate severe financial burden, which was not significantly associated with test results. Semi-structured interviews revealed variation in the frequency and severity of financial harms based on test results, with increased harm in those with false positive results. Conclusions. Financial harms of hepatocellular carcinoma screening vary by test result and can pose a barrier that must be considered when determining the optimal screening program. Chronic liver disease and cirrhosis mortality rates are disproportionately increasing in younger women in the United States between 2000 to 2020. Background and aims. Previous studies show that mortality from chronic liver disease, CLD, and cirrhosis is increasing in the United States. However, there are limited data on sex-specific mortality trends by age, race, and geographical location. The aim of this study was to conduct a comprehensive time trend analysis of liver disease-related mortality rates in the National Center of Health Statistics, NCHS, database. Methods. CLD and cirrhosis mortality rates between 20 million 2020, age-adjusted to the 2000 standard U.S. population, were collected from the NCHS database and categorized by sex and age into older adults, greater than or equal to 55 years, and younger adults, less than 55 years, race, non-Hispanic white, non-Hispanic black, Hispanic, non-Hispanic American Indian/Alaska Native, and non-Hispanic Asian/Pacific Islander, U.S. state and cirrhosis etiology. Time trends, annual percentage change, APC, and average APC, AAPC, were estimated using joint point regression using Monte Carlo permutation analysis. We used tests for parallelism and identicalness for sex-specific pairwise comparisons of mortality trends, two-sided p-value cutoff equals 0.05. Results. Between 20 million 2020, there were 716,651 deaths attributed to CLD and cirrhosis in the U.S., 35.68% women. In the overall population and in older adults, CLD and cirrhosis-related mortality rates were increasing similarly in men and women. However, in younger adults, 246,149 deaths, 32.72% women, the rate of increase was greater in women compared with men, OP equals 3.04 versus 1.08, OP difference equals 1.96, p less than 0.001, with non-identical non-parallel data, p-values less than 0.001. The disparity was driven by non-Hispanic white, OPT equals 4.51 versus 1.79, OPT difference equals 2.71, p less than 0.001, and Hispanic, OPT equals 1.89 versus minus 0.65, OPT difference equals 2.54, p equals 0.001 individuals. The disparity varied between U.S. states and was seen in 16 states, mostly in West Virginia. OPT equals 4.96 versus 0.88, OPT difference equals 4.08, p less than 0.001, and Pennsylvania, OPT equals 2.81 versus minus 1.02, OPT difference equals 3.84, p less than 0.001. Etiology-specific analysis did not show significant sex disparity in younger adults. Conclusions. Mortality rates due to CLD and cirrhosis in the U.S. are increasing disproportionately in younger women. This finding was driven by higher rates in non-Hispanic white and Hispanic individuals, with variation between U.S. states. Future studies are warranted to identify the reasons for these trends with the ultimate goal of improving outcomes. Real-world surgical and endoscopic recurrence based on risk profiles and prophylaxis utilization in postoperative Crohn's disease. Background and aims. Preoperative risk stratification may help guide prophylactic biologic utilization for the prevention of postoperative Crohn's disease, CD, recurrence. However, there are limited data exploring and validating proposed clinical risk factors. We aim to explore the preoperative clinical risk profiles, quantify individual risk factors, and assess the impact of biologic prophylaxis on postoperative recurrence risk in a real-world cohort. Methods. In this multicenter retrospective analysis, patients with CD who underwent ileocolonic resection, ICR, from 2009 to 2020 were identified. High risk, active smoking, greater than or equal to 2 prior surgeries, penetrating disease, and/or perianal disease, and low risk, non-smokers and age greater than 50 years, features were used to stratify patients. We assessed the risk of endoscopic, Rutgert score, greater than or equal to TOI-2B, and surgical recurrence by risk strata and biologic prophylaxis, less than or equal to 90 days postoperatively, with logistic and time to event analyses. Results. A total of 1,404 adult CD patients who underwent ICR were included. Of the high-risk factors, 2 or more ICRs, odds ratio or 1.71, 95% C, 1.13 to 2.57, active smoking or 1.73, 95% C, 1.17 to 2.53, penetrating disease or 1.41, 95% C, 1.02 to 1.94, and history of perianal disease alone or 1.99, 95% C, 1.42 to 2.79, were associated with surgical but not endoscopic recurrence. Surgical recurrence was lower in high-risk patients receiving prophylaxis versus not, 10.2% versus 16.7%, p equals 0.02, and endoscopic recurrence was lower in those receiving prophylaxis irrespective of risk strata, high risk, 28.1% versus 37.4%, p equals 0.03, and low risk, 21.1% versus 38.3%, p equals 0.002. Conclusions. Clinical risk factors accurately illustrate patients at risk for surgical recurrence, but have limited utility in predicting endoscopic recurrence. Biologic prophylaxis may be of benefit irrespective of risk stratification, and future studies should assess this. Next, we will be discussing articles from Clinical Infectious Diseases. Brain abscess caused by oral cavity bacteria, a nationwide, population-based cohort study. Background. Oral cavity bacteria are the most frequent etiology of brain abscess. Yet, data on the clinical presentation and outcome are scarce. Methods. We performed a nationwide, population-based study comprising all adults, aged greater than or equal to 18 years, with brain abscess due to oral cavity bacteria in Denmark from 2007 through 2020. Prognostic factors for unfavorable outcome, Glasgow Outcome Scale, 1 to 4, were examined using modified Poisson regression to compute adjusted relative risks, RRs, with 95% confidence intervals, Cs. Results. Among 287 identified patients, the median age was 58 years, interquartile range, 47 to 66, and 96 of 287, 33%, were female. Pre-existing functional impairment was absent or mild in 253 of 280, 90%, and risk factors for brain abscess included immunocompromise in 95 of 287, 33%, dental infection in 68 of 287, 24%, and ear-nose-throat infection in 33 of 287, 12%. Overall, a neurological deficit was present in 246 of 276, 86%, and in combination with headache and fever in 64 of 287, 22%. Identified microorganisms were primarily the Streptococcus aeruginosus group, Fusobacterium, Actinomyces, and Aggregatibacter spp, and 117 of 287, 41%, were polymicrobial. Unfavorable outcome occurred in 92 of 246, 37%, at 6 months after discharge and was associated with antibiotics before neurosurgery, RR, 3.28, 95% C, 1.53 to 7.04, rupture, RR, 1.89, 95% C, 1.34 to 2.65, and immunocompromise, RR, 1.80, 95% C, 1.29 to 2.51, but not with specific targeted antibiotic regimens. Identified dental infection was associated with favorable prognosis, RR, 0.58, 95% C, 0.36. 93. Conclusions. Brain abscess due to oral cavity bacteria often occurred in previously healthy individuals without predisposing dental infections. Important risk factors for unfavorable outcome were rupture and immunocompromise. However, outcome was not associated with specific antibiotic regimens supporting carbapenem-sparing strategies. Opportunistic treatment of hepatitis C infection among hospitalized people who inject drugs, Opportuni-C, a step-wedge cluster randomized trial. Background. We aim to evaluate the efficacy of opportunistic treatment of hepatitis C virus, HCV, infection among hospitalized people who inject drugs, PWID. Methods. We performed a pragmatic, step-wedge cluster randomized trial recruiting HCV RNA-positive individuals admitted for inpatient care in departments of internal medicine, addiction medicine, and psychiatry at 3 hospitals in Oslo, Norway. 7 departments were sequentially randomized to change from control conditions, standard of care referral to outpatient care, to intervention conditions, immediate treatment initiation. The primary outcome was treatment completion, defined as dispensing the final package of the prescribed treatment within 6 months after enrollment. Results. A total of 200 HCV RNA-positive individuals were enrolled between October 1, 2019 and December 31, 2021, mean age 47.4 years, 72.5% male, 60.5% injected past 3 months, 20.4% cirrhosis. Treatment completion was accomplished by 67 of 98, 68.4%, 95% confidence interval, C, 58.2 to 77.4, during intervention conditions and by 36 of 102, 35.3%, 95% C, 26.1 to 45.4, during control conditions, risk difference 33.1%, 95% C, 20.0 to 46.2, risk ratio 1.9, 95% C, 1.4 to 2.6. The intervention was superior in terms of treatment completion, adjusted odds ratio, AOR, 4.8, 95% C, 1.8 to 12.8, P equals 0.002, and time to treatment initiation, adjusted hazard ratio, R, 4.0, 95% C, 2.5 to 6.3, P less than 0.001. Sustained virologic response was documented in 60 of 98, 61.2%, 95% C, 50.8 to 70.9, during intervention and in 66 of 102, 64.7%, 95% C, 54.6 to 73.9, during control conditions. Conclusions. An opportunistic test and treat approach to HCV infection was superior to standard of care among hospitalized POID. The model of care should be considered for broader implementation. Early mortality after the first dose of COVID-19 vaccination, a target trial emulation. Background: vaccine hesitancy persists alongside concerns about the safety of coronavirus disease 2019, COVID-19, vaccines. We aim to examine the effect of COVID-19 vaccination on risk of death among U.S. veterans. Methods: we conducted a target trial emulation to estimate and compare risk of death up to 60 days under two COVID-19 vaccination strategies: vaccination within 7 days of enrollment versus no vaccination through follow-up. The study cohort included individuals aged greater than or equal to 18 years enrolled in the Veterans Health Administration system and eligible to receive a COVID-19 vaccination according to guideline recommendations from March 1, 2021 through July 1, 2021. The outcomes of interest included deaths from any cause and excluding a COVID-19 diagnosis. Observations were cloned to both treatment strategies, censored, and weighted to estimate per protocol effects. Results: we included 358,507 veterans. Under the vaccination strategy, 364,993 received vaccine within 7 days. At 60 days, there were 156 deaths per 100,000 veterans under the vaccination strategy versus 185 deaths under the no vaccination strategy, corresponding to an absolute risk difference of -25.9, 95% confidence limit, CL, -59.5 to 2.7, and relative risk of 0.86, 95% CL, 0.7 to 1.0. When those with a COVID-19 infection in the first 60 days were censored, the absolute risk difference was -20.6, 95% CL, -53.4 to 16.0, with a relative risk of 0.88, 95% CL, 0.7 to 1.1. Conclusions: vaccination against COVID-19 was associated with a lower but not statistically significantly different risk of death in the first 60 days. These results agree with prior scientific knowledge suggesting vaccination is safe with the potential for substantial health benefits. Next, we will be discussing articles from Journal of Infectious Diseases. Early initiation of antiretroviral therapy preserves the metabolic function of CD4 plus T cells in subtype C human immunodeficiency virus 1 infection. Background: immune dysfunction often persists in people living with human immunodeficiency virus, HIV, who are on antiretroviral therapy, ART, clinically manifesting as HIV-1 associated comorbid conditions. Early ART initiation may reduce incidence of HIV-1 associated immune dysfunction and comorbid conditions. Immunometabolism is a critical determinant of functional immunity. We investigated the effect of HIV-1 infection and timing of ART initiation on CD4 plus T cell metabolism and function. Methods: longitudinal blood samples from people living with HIV who initiated ART during hyperacute HIV-1 infection, HHI, before peak viremia, or chronic HIV-1 infection, CHI, were assessed for the metabolic and immune functions of CD4 plus T cells. Metabolite uptake and mitochondrial mass were measured using fluorescent analogs and mito tracker green accumulation, respectively, and were correlated with CD4 plus T cell effector functions. Results: initiation of ART during HHI prevented dysregulation of glucose uptake by CD4 plus T cells, but glucose uptake was reduced before and after ART initiation in CHI. Glucose uptake positively correlated with interleukin-2 and tumor necrosis factor alpha production by CD4 plus T cells. CHI was associated with elevated mitochondrial mass and effector memory CD4 plus T cells that persisted after ART and correlated with PD-1 expression. Conclusions: ART initiation in HHI largely prevented metabolic impairment of CD4 plus T cells. ART initiation in CHI was associated with persistently dysregulated immunometabolism of CD4 plus T cells, which was associated with impaired cellular functions and exhaustion. Next, we will be discussing articles from Arthritis and Rheumatology. Weight loss induced by anti-obesity medications and all-cause mortality among patients with knee or hip osteoarthritis. Objective: the current guidelines recommend weight loss for patients with overweight or obesity and knee or hip osteoarthritis, OA. However, there is a paucity of data on the relation of weight loss to death among patients with OA. We aim to examine the relation of the rate of weight loss induced by anti-obesity medications over 1 year to all-cause mortality among patients with overweight or obesity and knee or hip OA. Methods: using the IQVIA Medical Research Database, we identified people with overweight or obesity, knee or hip OA. We emulated analyses of a hypothetical target trial to assess the effect of slow to moderate, 2% to 10%, or fast, greater than or equal to 10%, weight loss induced by the initiation of anti-obesity medications within 1 year on all-cause mortality and secondary outcomes over 5 years follow-up. Results: among 6,524 participants, the 5-year all-cause mortality rates were 5.3%, 4.0%, and 5.4% for weight gain or stable, slow to moderate weight loss, and fast weight loss arms, respectively. Compared with the weight gain or stable arm, hazard ratios of all-cause mortality were 0.72, 95% confidence interval, c. 0.56 to 0.92, for the slow to moderate weight loss arm and 0.99, 95% c. 0.67 to 1.44, for the fast weight loss arm. We found dose-response protective effects of weight loss on incident hypertension, type 2 diabetes, and venous thromboembolism at a slightly higher risk of cardiovascular disease, albeit not statistically significant, in the fast rate of weight loss arm and in the weight gain or stable arm, and no significant relations of weight loss to the risk of cancer. Conclusion: in this population-based study, a slow to moderate, but not fast, rate of weight loss induced by anti-obesity medications is associated with a lower risk of all-cause mortality in people with overweight or obesity and knee or hip OA. Next we will be discussing articles. American College of Cardiology. Comparison of IVUS-guided versus angiography-guided angioplasty for the outcomes of drug-coated balloon in the treatment of femoropopliteal artery disease. The IVUS-DCB trial showed that IVUS-guided drug-coated balloon angioplasty improves primary patency. Description: the goal of the trial was to evaluate intravascular ultrasound, IVUS-guided drug-coated balloon angioplasty compared with angiography-guided drug-coated balloon angioplasty among patients with femoropopliteal artery disease. Study design: randomized, parallel, blinded. Patients with symptomatic femoropopliteal artery disease were randomized to IVUS-guided drug-coated balloon angioplasty, N equals 119, versus angiography-guided drug-coated balloon angioplasty, N equals 118. Total number of enrollees, 237. Duration of follow-up, 12 months. Mean patient age, 69 years. Percentage female, 14%. Percentage with diabetes, 60%. Inclusion criteria: symptomatic femoropopliteal artery disease. Rutherford Category 2 to 5. Principal findings: the primary outcome, primary patency, at 12 months was 83.8% in the IVUS-guided group versus 70.1% in the angiography-guided group, p equals 0.01. Among task AB lesions, there was no difference between treatment strategies, p equals 0.52. However, in task CD lesions, there was a significant benefit favoring IVUS-guided drug-coated balloon angioplasty, p equals 0.002. Interpretation: among patients with symptomatic femoropopliteal artery disease, IVUS-guided drug-coated balloon angioplasty was associated with an improvement in primary patency compared with angiography-guided drug-coated balloon angioplasty. Benefit was especially evident among complex lesions. Next we will be discussing articles from journals of the American College of Cardiology. Effect of sodium glucose cotransporter 2 inhibitors in adults with congenital heart disease. Background: heart failure, HF, is the principal cause of morbidity and mortality in adults with congenital heart disease, ACHD. Robust evidence-based treatment options are lacking. Objectives. This study aims to evaluate the safety, tolerability, and short-term HF-related effects of sodium glucose cotransporter 2 inhibitors, SGLT2I, in a real-world ACHD population. Methods. All patients with ACHD treated with SGLT2I in 4 European ACHD centers were included in this retrospective study. Data were collected from 1 year before starting SGLT2I to the most recent follow-up. Data on side effects, discontinuation, mortality, and hospitalizations were collected. Results. In total, 174 patients with ACHD were treated with SGLT2I from April 2016 to July 2023. The mean age was 48.7 plus or minus 15.3 years, 72, 41.4%, were female, and 29, 16.7%, had type 2 diabetes mellitus. 10, 5.7%, patients had mild, 75, 43.1%, moderate, and 89, 51.1%, severe congenital heart disease. HF was the most frequent starting indication, N equals 162, 93.1%, followed by type 2 diabetes, N equals 11, 6.3%, and chronic kidney disease, N equals 1, 0.6%. At median follow-up of 7.7 months, Q1 Q3, 3.9 to 13.2 months, 18 patients, 10.3%, reported side effects, 12, 6.9%, permanently discontinued SGLT2I, and 4, 2.3%, died of SGLT2I unrelated causes. A significant reduction in the HF hospitalization rate was observed from 6 months before to 6 months after starting SGLT2I, relative rate equals 0.30, 95% C, 0.14 to 0.62, P equals 0.001. Conclusions. SGLT2I generally seems safe, well tolerated, and potentially beneficial in patients with ACHD. SGLT2I was associated with a threefold reduction in the 6-month HF hospitalization rate. These results warrant prospective randomized investigation of the potential benefits of SGLT2I for patients with ACHD. Next, we will be discussing articles from Journal of Clinical Endocrinology and Metabolism. Modification effects of albuminuria on the association between kidney function and development of anemia in diabetes. Context. Previous studies failed to adjust for estimated glomerular filtration rate, EFR, in evaluating the association between albuminuria and anemia development, and we aim to investigate whether albuminuria independently affects anemia development. Methods. We conducted a retrospective cohort study and retrospectively identified adults with diabetes from a Japanese nationwide clinical database, JMDC, Tokyo, Japan. To assess the modification effects of albuminuria on the association between EFR and anemia development, we estimated prevalence of anemia, defined as hemoglobin less than 13 g/dl in men and less than 12 g/dl in women, using a modified Poisson regression and marginal standardization form of predictive margins, stratified by albuminuria severity after adjusting for EFR. Hence, we revealed at which EFR level this modification effect appeared and the extent to which this modification effect increased the prevalence of anemia. Results. We identified 327,999 data points from 48,056 individuals, normoalbuminuria, 186,472, 56.9%, microalbuminuria, 107,170, 32.7%, and macroalbuminuria, 34,357, 10.5%. As EFR declined, anemia prevalence increased. Albuminuria severity modified this association induced by decreased EFR among individuals with EFR less than 30 ml per minute /1.73 m2 after adjusting for multivariable factors, including age, sex, comorbidities, and medication use. Compared with the normoalbuminuric group, the macroalbuminuric group had a 5% to 20% higher anemia prevalence among individuals with EFR of less than 30 ml per minute /1.73 m2. Conclusion. We revealed that the severity of albuminuria modified the association between FFR and anemia development among individuals with FFR less than 30 ml per minute /1.73 m2, highlighting the modification effect of albuminuria on the association between kidney function and anemia development in diabetes. Association of urine albumin to creatinine ratio with cardiovascular outcomes in patients with type 2 diabetes mellitus. Context: the urinary albumin to creatinine ratio, UACR, is a widely used indicator of albuminuria and has predictive value for adverse cardiovascular events. Objective: to evaluate the correlation between the WACR and the risk of developing major adverse cardiovascular events, MACEs, and total mortality in patients with type 2 diabetes mellitus, T2DM. Methods: this post-hoc analysis included 171 participants from the Action to Control Cardiovascular Risk in Diabetes, ACCORD, study and the ACCORD follow-up study, Accordion, with baseline WACR data. The natural logarithm ln of each WACR measurement was calculated. Univariate and multivariate Cox proportional hazard regression analyses were conducted to examine the association between the WACR and the risk of MACEs and total mortality. The additional predictive value of WACR was further evaluated. Similar methods were used to analyze the correlation between the WACR and MACEs and total mortality within the normal range. Results: during a median follow-up period of 8.83 years, 1808, 17.78%, participants experienced MACEs, and there were 1934, 19.01%, total deaths. After adjusting for traditional cardiovascular risk factors, the multivariate analysis revealed a significant association between the WACR and the risk of MACEs and total mortality. The inclusion of WACR in the conventional risk model enhanced the predictive efficacy for MACEs and total mortality. Conclusion: an elevated WACR is associated with a higher risk of MACEs and total mortality in patients with T2DM, even when it falls within the normal range. The WACR improves prediction of MACE and total mortality risk in patients with T2DM. Next, we will be discussing articles from Neurology. Association of time to thrombolysis with early reperfusion after alteplase and tenecteplase in patients with large vessel occlusion. Background and objectives. Early treatment with intravenous alteplase increases the probability of lytic-induced reperfusion in large vessel occlusion, LVO, patients. The relationship of tenecteplase-induced reperfusion and the timing of thrombolytic administration has not been explored. In this study, we performed a comparative analysis of tenecteplase and alteplase reperfusion rates and assessed their relationship to the time of thrombolytic administration. Methods: patients who were initially treated with a thrombolytic within 4.5 hours of symptom onset were pooled from the Royal Melbourne Stroke Registry, Extend IA, Extend IATNK, and Extend IATNK Part 2 trials. The primary outcome, thrombolytic-induced reperfusion, was defined as the absence of retrievable thrombus or greater than 50% reperfusion at initial angiographic assessment, or repeat CT perfusion/angiography. We compared the treatment effect of tenecteplase and alteplase through fixed effects Poisson regression modeling. Results: among 846 patients included in the primary analysis, early reperfusion was observed in 173, 20% patients, tenecteplase, 98,470, 21%, onset to thrombolytic time, 132 minutes, interquartile range, IQR, 99 to 170, and thrombolytic to assessment time, 61 minutes, IQR, 39 to 96, alteplase, 75,376, 19%, onset to thrombolytic time, 143 minutes, IQR, 105 to 180, thrombolytic to assessment time, 92 minutes, IQR, 63 to 144. Earlier onset to thrombolytic administration times were associated with an increased probability of thrombolytic-induced reperfusion in patients treated with either tenecteplase, adjusted risk ratio R, 1.05 per 15 minutes, 95% confidence interval, C, 1.00 to 1.12 or alteplase, R 1.06 per 15 minutes, 95% C 1.00 to 1.13. Tenecteplase remained associated with higher rates of reperfusion versus alteplase after adjustment for onset to thrombolytic time, occlusion site, thrombolytic to assessment time, and study as a fixed effect, adjusted incidence rate ratio, 1.41, 95% C 1.02 to 1.93. No significant treatment by time interaction was observed, p equals 0.87. Discussion. In patients with LVO presenting within 4.5 hours of symptom onset, earlier thrombolytic administration increased successful reperfusion rates. Compared with alteplase, tenecteplase was associated with a higher probability of lytic-induced reperfusion, independent of onset to lytic administration times. Identification of distinct brain MRI phenotypes and their association with long-term dementia risk in community-dwelling older adults. Background and objectives. Individual brain MRI markers only show at best a modest association with long-term occurrence of dementia. Therefore, it is challenging to accurately identify individuals at increased risk for dementia. We aim to identify different brain MRI phenotypes by hierarchical clustering analysis based on combined neurovascular and neurodegenerative brain MRI markers, and to determine the long-term dementia risk within the brain MRI phenotype subgroups. Methods. Hierarchical clustering analysis based on 32 combined neurovascular and neurodegenerative brain MRI markers in community-dwelling individuals of the age-gene/environment susceptibility Reykjavik study was applied to identify brain MRI phenotypes. A Cox proportional hazards regression model was used to determine the long-term risk for dementia per subgroup. Results. We included 3,056 participants and identified 15 subgroups with distinct brain MRI phenotypes. The phenotypes ranged from limited burden, mostly irregular white matter hyperintensity, WMH, shape and cerebral atrophy, mostly irregularly WMHs and microbleeds, mostly cortical infarcts and atrophy, mostly irregularly shaped WMH and cerebral atrophy to multi-burden subgroups. Each subgroup showed different long-term risks for dementia, min-max range hazard ratios, HRs, 1.01 to 6.18, mean time to follow-up 9.9 plus or minus 2.6 years, especially the brain MRI phenotype with mainly WMHs and atrophy showed a large increased risk, HR 6.18, 95% C 3.37 to 11.32. Discussion. Distinct brain MRI phenotypes can be identified in community-dwelling older adults. Our results indicate that distinct brain MRI phenotypes are related to varying long-term risks of developing dementia. Brain MRI phenotypes may in the future assist in an improved understanding of the structural correlates of dementia predisposition. Next, we will be discussing articles from CHEST. Ozanimod therapy in patients with COVID-19 requiring oxygen support. Background. Sphingosine 1-phosphate receptor ligands, SRLs, dampen immunopathologic damages in models of viral pneumonia. Research question. Is it feasible to administer an SRL therapy, here ozanimod, OZA, to acutely ill patients infected with SARS-CoV-2? Study design and methods. The prospective randomized open-label COVID-19 ozanimod intervention, COZI, pilot trial was conducted in 3 Canadian hospitals. Patients admitted for COVID-19 requiring oxygen were eligible. Randomization was stratified for risk factors of poor outcome and oxygen needs at inclusion. Participants were allocated to standard of care or to standard of care plus OZA. OZA, oral, once daily, incremental dosage, was administered for a maximum of 14 days. Primary endpoint investigated for size effect and variance over time was the assessment of safety and efficacy, evaluated by the daily score on the World Health Organization adapted 6-point ordinal scale for clinical improvement analyzed under the intention to treat principle. Results. 23 patients were randomized to the standard of care arm, and 20 were randomized to the OZA arm from September 2020 to February 2022. Evaluation of efficacy showed non-significant reductions of median, interquartile range, duration of respiratory support, 6, 3 to 10 versus 9, 4 to 12 days, p equals 0.34, median duration of hospitalization 9, 6 to 12 versus 10, 6 to 18 days, p equals 0.20, and median time to clinical improvement, 4, 3 to 7 versus 7, 3 to 11 days, p equals 0.12, for OZA compared with standard of care, respectively. Heart rate was significantly lower with OZA, 65, 63 to 67, versus 71, 69 to 72, beats per minute, p less than 0.0001. However, QT and PR intervals were not affected. No severe adverse drug reaction was reported. Interpretation. To our knowledge, SRL utility in severe pneumonia has never been tested in patients. This study shows for the first time that this new pharmacologic agent may safely be administered to patients hospitalized for viral pneumonia, with potential clinical benefits. Bradycardia was frequent but well tolerated. The association between pre-pandemic ICU performance and mortality variation in COVID-19. Background. During the COVID-19 pandemic, ICUs remained under stress and observed elevated mortality rates and high variations of outcomes. A knowledge gap exists regarding whether an ICU performing best during non-pandemic times would still perform better when under high pressure compared with the least performing ICUs. Research question. Does pre-pandemic ICU performance explain the risk-adjusted mortality variability for critically ill patients with COVID-19? Study design and methods. This study examined a cohort of adults with real-time polymerase chain reaction confirmed COVID-19 admitted to 156 ICUs in 35 hospitals from February 16, 2020, through December 31, 2021, in Brazil. We evaluated crude and adjusted in-hospital mortality variability of patients with COVID-19 in the ICU during the pandemic. Association of baseline, pre-pandemic, ICU performance and in-hospital mortality was examined using a variable life-adjusted display, VLAD, during the pandemic and a multivariable mixed regression model adjusted by clinical characteristics, interaction of performance with the year of admission, and mechanical ventilation at admission. Results. 35,619 patients with confirmed COVID-19 were evaluated. The median age was 52 years, median simplified acute physiology score 3 was 42, and 18% underwent invasive mechanical ventilation. In-hospital mortality was 13% and 54% for those receiving invasive mechanical ventilation. Adjusted in-hospital mortality ranged from 3.6% to 63.2%. VLAD in the most efficient ICUs was higher than the overall median in 18% of weeks, whereas VLAD was 62% and 84% in the underachieving and least efficient groups, respectively. The least efficient baseline ICU performance group was associated independently with increased mortality, or 2.30, 95% C, 1.45 to 3.62, after adjusting for patient characteristics, disease severity, and pandemic surge. Interpretation. ICUs caring for patients with COVID-19 presented substantial variation in risk-adjusted mortality. ICUs with better baseline, pre-pandemic, performance showed reduced mortality and less variability. Our findings suggest that achieving ICU efficiency by targeting improvement in organizational aspects of ICUs may impact outcomes, and therefore should be a part of the preparedness for future pandemics. Impact of left heart disease risk factors on outcomes in pulmonary arterial hypertension therapy. Background. Current guidelines recommend initial monotherapy for pulmonary arterial hypertension (PAH) with cardiopulmonary comorbidities, despite limited available evidence to guide management. Research question. Do left heart disease, LHD, risk factors have an impact on treatment response and influence applicability of risk assessment in a real-world cohort of patients with PA? Study design and methods. The ambrisentan and tadalafil in patients with pulmonary arterial hypertension, AMBITION, trial criteria was used to define the phenotype of patients with PA with risk factors for LHD. Treatment strategy, functional outcome, long-term survival, and risk discrimination were compared with a reference PA cohort using the Pulmonary Hypertension Society of Australia and New Zealand Registry. Results. A total of 487 incident patients with PA diagnosed between 2011 and 2020 were included. Of these, 103, 21.1%, fulfilled the definition of PA with LHD risk factors, with 384, 78.9%, remaining as the reference group. Patients in the PA with LHD risk factors group were older, 66 plus or minus 13 versus 58 plus or minus 19 years, p less than 0.001, had lower pulmonary vascular resistance, 393 plus or minus 266 versus 708 plus or minus 391 dyne.s/cm5, p equals 0.031, and had worse 6-minute walk distance, 286 plus or minus 130 versus 327 plus or minus 136 meters, p equals 0.005, at diagnosis. The PA with LHD risk factors group was less likely to receive initial combination therapy, 27% versus 44%, p equals 0.02. Changes in 6-minute walk distance at 12 months were similar in both groups, 43 plus or minus 77 meters in the PA with LHD risk factors group and 50 plus or minus 90 meters in the reference group, p equals 0.50, including when stratified by initial treatment strategy. PA with LHD risk factors group versus reference PA group, monotherapy, 40 plus or minus 81 versus 38 plus or minus 95 meters, p equals 0.87, combination therapy, 53 plus or minus 78 versus 64 plus or minus 106 meters, p equals 0.511. Functional class improvements were also similar in both groups. Reveal Registry 2.0 risk score effectively discriminated risk in both populations. C statistic equals 0.756 for the PA with LHD risk factors group, and C statistic equals 0.750 for the reference PA group. There was no difference in survival between the two groups. Log rank test, p equals 0.29. Interpretation. In a real-world cohort, patients with PA with LHD risk factors were less likely to be exposed to initial combination therapy. Nevertheless, selected patients with PA with LHD risk factors who were treated with initial combination therapy derived similar functional response compared with the reference group. Further studies are needed to phenotype patients with PA with cardiopulmonary comorbidities who may benefit from initial combination therapy. Next, we will be discussing articles from the American Journal of Respiratory and Critical Care Medicine. Oxygen saturation targets and cognitive and functional outcomes in mechanically ventilated adults. Rationale: among mechanically ventilated critically ill adults, the pilot, pragmatic investigation of optimal oxygen targets trial demonstrated no difference in ventilator-free days among lower, intermediate, and higher oxygen saturation targets. The effects on long-term cognition and related outcomes are unknown. Objectives: to compare the effects of lower, 90%, range, 88 to 92%, intermediate, 94%, range, 92 to 96%, and higher, 98%, range, 96 to 100%, oxygen saturation targets on long-term outcomes. Methods: 12 months after enrollment in the pilot trial, blinded neuropsychological raters conducted assessments of cognition, disability, employment status, and quality of life. The primary outcome was global cognition as measured using the Telephone Montreal Cognitive Assessment. In a subset of patients, an expanded neuropsychological battery measured executive function, attention, immediate and delayed memory, verbal fluency, and abstraction. Measurements and main results: a total of 501 patients completed follow-up, including 142 in the lower, 186 in the intermediate, and 173 in the higher oxygen target groups. Median, interquartile range, peripheral oxygen saturation values in the lower, intermediate, and higher target groups were 94%, 91 to 96%, 95%, 93 to 97%, and 97%, 95 to 99%, respectively. Telephone Montreal Cognitive Assessment Score did not differ between lower and intermediate, adjusted odds ratio, or 1.36, 95% confidence interval, C, 0.92 to 2.00, intermediate and higher, adjusted or, 0.90, 95% C, 0.62 to 1.29, or higher and lower, adjusted or, 1.22, 95% C, 0.83 to 1.79, target groups. There was also no difference in individual cognitive domains, disability, employment, or quality of life. Conclusions: among mechanically ventilated critically ill adults who completed follow-up at 12 months, oxygen saturation targets were not associated with cognition or related outcome. Association between age and mortality in pediatric and adult acute respiratory distress syndrome. Rationale: the epidemiology, management, and outcomes of acute respiratory distress syndrome, ARDS, differ between children and adults, with lower mortality rates in children despite comparable severity of hypoxemia. However, the relationship between age and mortality is unclear. Objective: we aim to define the association between age and mortality in ARDS, hypothesizing that it would be nonlinear. Methods: we performed a retrospective cohort study using data from 2 pediatric ARDS observational cohorts, N equals 1,236, multiple adult ARDS trials, N equals 5,547, and an adult observational ARDS cohort, N equals 1,079. We aligned all datasets to meet Berlin criteria. We performed unadjusted and adjusted logistic regression using fractional polynomials to assess the potentially nonlinear relationship between age and 90-day mortality, adjusting for sex, POW2/VO2, immunosuppressed status, year of study, and observational versus randomized controlled trial, treating each individual study as a fixed effect. Measurements and main results: there were 7,862 subjects with median ages of 4 years in the pediatric cohorts, 52 years in the adult trials, and 61 years in the adult observational cohort. Most subjects, 43%, had moderate ARDS by Berlin criteria. 90-day mortality was 19% in the pediatric cohorts, 33% in the adult trials, and 67% in the adult observational cohort. We found a nonlinear relationship between age and mortality, with mortality risk increasing at an accelerating rate between 11 and 65 years of age, after which mortality risk increased more slowly. Conclusions: there was a nonlinear relationship between age and mortality in pediatric and adult ARDS. Next we will be discussing articles is from Clinical Journal of American Society of Nephrology. Time-varying determinants of graft failure in pediatric kidney transplantation in Europe. Background: little is known about the time-varying determinants of kidney graft failure in children. Methods: we performed a retrospective study of primary pediatric kidney transplant recipients, younger than 18 years, from the Eurotransplant Registry, 1990 to 2020. Piecewise exponential additive mixed models were applied to analyze time-varying recipient, donor, and transplant risk factors. Primary outcome was death-censored graft failure. Results: we report on 4,528 kidney transplantations, of which 68% with deceased and 32% with living donor. 1,638 recipients experienced graft failure, and 168 died with a functioning graft. Between 2011 and 2020, the 5-year graft failure risk was 10% for deceased donor and 4% for living donor kidney transplant recipients. Risk of graft failure decreased fivefold from 1990 to 2020. The association between living donor transplantation and the lower risk of graft failure was strongest in the first month post-transplant, adjusted hazard ratio, 0.58, 95% confidence interval, 0.46 to 0.73, and remained statistically significant until 12 years post-transplant. Risk factors for graft failure in the first 2 years were deceased donor younger than 12 years or older than 46 years, potentially recurrent kidney disease, and panel-reactive antibody greater than 0%. Other determinants of graft failure included dialysis before transplantation, until 5 years post-transplant, human leukocyte antigen mismatch 2 to 4, 0 to 15 years post-transplant, human leukocyte antigen mismatch 5 to 6, 2 to 12 years post-transplant, and hemodialysis, 8 to 14 years post-transplant. Recipients older than 11 years at transplantation had a higher risk of graft failure 1 to 8 years post-transplant compared with other age groups, whereas young recipients had a lower risk throughout follow-up. Analysis of the combined effect of post-transplant time and recipient age showed a higher rate of graft failure during the first 5 years post-transplant in adolescents compared with young transplant recipients. In contrast to deceased donor younger than 12 years, deceased donor older than 46 years was consistently associated with a higher graft failure risk. Conclusions. We report a long-term inverse association between living donor kidney transplantation and the risk of graft failure. The determinants of graft failure varied with time. There was a significant cumulative effect of adolescence and time post-transplant. The ideal donor age window was dependent on time post-transplant. Trends and specific causes of cardiovascular mortality after kidney transplantation in Finland. Background. Cardiovascular diseases are an important cause of mortality in patients who have undergone kidney transplantation, but the knowledge on trends of cardiovascular mortality and specific causes of cardiovascular death among these patients is scarce. Methods. Our aim was to compare the cardiovascular mortality rates after kidney transplantation in Finland between 1990 to 1999, 2000 to 2009, and 2010 to 2019 using data from the Finnish Registry for Kidney Diseases. We analyzed 1-year and long-term cardiovascular mortality rates as well as the specific causes of cardiovascular death and the trends in them. Results. In total, 4,946 patients underwent first kidney transplantation in 1990 to 2019. During the follow-up time, median 8.3 years, interquartile range 4.0 to 14.5, there were 1,392 deaths, of which 582 were cardiovascular deaths. In an unadjusted Cox regression model, the risk of long-term cardiovascular mortality was similar in the different periods. However, when adjusted for age, sex, duration of dialysis, and cause of kidney disease, the long-term cardiovascular mortality risk was significantly lower in 2000 to 2009 and 2010 to 2019, hazard ratio 0.60, 95% confidence interval, 0.49 to 0.73, and hazard ratio 0.51, 95% confidence interval, 0.39 to 0.66, respectively, compared with 1990 to 1999. The results were similar regarding 1-year cardiovascular mortality. The distribution of different causes of cardiovascular death remained unchanged during the study period, with coronary artery disease accounting for 47% of deaths. During the first year after transplantation, pulmonary embolisms and arrhythmias were more common than in the long term. Conclusions. Cardiovascular disease remained the most common cause of death in kidney transplant recipients, but adjusted cardiovascular mortality risk has decreased significantly during the past 3 decades. Coronary artery disease was the most frequent cause of cardiovascular death, and the proportion of coronary artery disease-related cardiovascular deaths increased after the first year after transplantation. Next we will be discussing articles is from Kidney International Reports. A randomized controlled study of efficacy and safety of accelerated versus standard hepatitis B vaccination in patients with advanced CKD. Introduction. Hepatitis B virus, HBV, vaccination is crucial for seronegative patients with advanced chronic kidney disease, CKD, for protection during dialysis while preparing for transplantation. A standard regimen for HBV vaccination requires 24 weeks to be completed. An accelerated HBV vaccination regimen completed within 8 weeks has shown early effective seroconversion in healthcare workers. However, data for patients with advanced CKD are limited. Methods. A randomized controlled trial was conducted in patients with advanced CKD, estimated glomerular filtration rate, GFR, less than 30 milliliters per minute per 1.73 square meters, and patients on dialysis. The patients were randomly assigned to either a standard HBV vaccination regimen, Engerix-B, 40G at 0, 4, 8, and 24 weeks, or an accelerated regimen, 40G at 0, 1, 4, and 8 weeks. The hepatitis B surface antibodies, anti-HBs, were measured at 12, 28, and 52 weeks. Seroconversion were defined as anti-HBs greater than or equal to 10 IU/L. Results. At 12 weeks, among the intention to treat, ITT, Population of 133 participants, 65 in the accelerated and 68 in the standard groups. The accelerated group demonstrated significantly higher rates of seroconversion, 83.08% versus 63.24%, p equals 0.01. In the per-protocol (pp) analysis of 125 patients, 62 in the standard and 63 in the accelerated groups, the accelerated group exhibited higher seroconversion rate compared with the standard group, 85.71% versus 69.35%, p equals 0.03. At 28 and 52 weeks, the seroconversion rates were similar between the two groups. Conclusion. In patients with advanced CKD, the accelerated HBV vaccination regimen demonstrated a significantly higher seroconversion rate at 12 weeks of vaccination. This finding suggests that the accelerated regimen is an effective option to achieve rapid seroconversion before initiating hemodialysis or before undergoing kidney transplantation. Exploring preconceptions as barriers to peritoneal dialysis eligibility, a global scenario-based survey of kidney care physicians. Introduction. Despite the growing number of patients requiring kidney replacement therapy, KRT, peritoneal dialysis, PD, is underutilized globally. A contributory factor may be clinician myths about its use. The aim of this study was to explore perceptions about PD initiation by clinicians according to various physical, social, and clinical characteristics of patients. Methods. An online global survey, in English and Thai, was administered to ascertain nephrologists' and nephrology trainees' decisions on recommending PD as a treatment modality. Results. A total of 645 participants, 522 nephrologists, and 123 trainees, 56% male, from 54 countries, 66% from high-income countries, HICS, 22% from upper-middle-income countries, UMICS, 12% from lower-middle-income countries, and 1% from low-income countries, LICs, completed the survey. Of the respondents, 81% identified as attending physicians or consultants, and 19% identified as trainees or other. PD was recommended for most scenarios, including repeated exposures to heavy lifting, swimming, especially in a private pool and ocean, among patients with cirrhosis or cognitive impairment with available support, and those living with a pet if a physical separation can be achieved during PD. Certain abdominal surgeries were more acceptable to proceed with PD, hysterectomy, 90%, compared to others, hemicolectomy, 45%. Similar variation was noted for different types of stomas, nephrostomies, 74%, suprapubic catheters, 53%, and ileostomies, 27%. Conclusion. The probability of recommending PD in various scenarios was greater among clinicians from HICS, larger units, and consultants with more clinical experience. There is a disparity in recommending PD across various clinical scenarios driven by experience, unit-level characteristics, and region of practice. Globally, evidence-informed education is warranted to rectify misconceptions to enable greater PD uptake. Thank you for listening to This Week in Medicine, your filtered medical journal summary. Have a great week ahead, stay blessed and be humane.